Thanks.
Good evening, everyone. It's nice to see that we have a nice variety on the group that has joined us for this spectacular webinar. We're mainly focusing on adolescent care, and I'm sure some of you will relate to what the speakers will be speaking about today. And we hope that you will leave this webinar with some information and tools to help you in you managing your adolescence in your environment. Um, so I'm going to hand you over to Tracy and Sue, who are going to run through um, the rest of the program, as well as give you some information about the do's and don'ts during the webinar. So I hand you over to Tracy.
Thanks, Sam. Just to welcome everybody and just to quickly introduce our webinar team. It's myself, Tracy, Sue from Patch, and then Sam, our chairman, and also Lucy, who's on our committee as well. So welcome everybody and thank you for attending. Just to say, we've just got a few ground rules, if you don't mind. Just keeping yourselves on mute just as we work through this webinar. You're welcome to put your hand up when we have the Q&As and ask a question. If you do have anything to ask, I would say please write your question early on in the webinar. In the chat, put your question there, and then at the end, as we work through them, we can answer those and give them to the presenter to chat about. Cameras on, if possible. We know it's difficult for everybody, but if you are going to be asking a question or feel like you want to ask or put something to the group, please put your camera on. And then we just ask that we do respect privacy if something is being shared in this group, and we ask that we just keep it to with no names or indications of who or what the person is. And then right at the end, we do ask you to stay online just to complete our online survey. It does help us with monitoring and evaluation and how we can improve our services and our webinars for all of you. So again, thank you everybody who did register. I think we're in for an amazing evening and much to learn. And I'm going to now hand over to Sue, who's going to introduce our guest presenters for this evening.
Hi, everybody, and a warm welcome. I'm just having a look. We've already got 78 people on the webinar, so I think that's just an indication of what an important topic we're going to be covering this evening. And I couldn't think of two more qualified people to actually be talking to you about these topics. Dr. Jivanesh Chetty and Tracy Brand. One is a doctor and one is a social worker. So you got the clinical and you've got the psychosocial represented in the two of them. The next slide, Tracy. Just a little bit more about Dr. Jivanesh Chetty, or Jiv as we know him. He's a clinician with extensive expertise in the comprehensive management of adult and pediatric HIV and TB. I know he's in demand. He literally was just presenting, I think, for his diploma that he's doing now. So he's an eternal student. And he's a strong advocate for clinical education, responsible for training medical interns, students, and international trainees to foster the next generation of healthcare professionals. Jivanesh is a collaborative leader in managing highly complex cases, contributing to multidisciplinary teams to enhance patient outcomes. So I'm not going to read through all his qualifications. You can have a look underneath there. I think he's highly qualified to speak to us tonight, and we're so looking forward to his presentation. And then straight after his presentation will be Tracy Brand. Tracy I've known for years and years. Tracy has been in the field from 2008, where she started the Big Shoes Foundation, when the Big Shoes Foundation, which was providing pediatric palliative care in the Durban area, closed down, her and Dr. Julia Ambler started Umduduzi Hospice Care for Children. And I'm quite sure that's an organization that most of you have heard of. She's been involved in teaching, training doctors, nurses, and social workers in pediatric palliative care and designed course work material for this purpose. And this is, I think, the most important, is that she provides direct services to children and to teenagers and their families. And she, on top of that, she's also an honorary lecturer in the Department of Pediatrics at UKZN, Nelson Mandela Medical School. So I think you'll all agree that we have very well qualified presenters tonight. And straight after Dr. Chetty's presentation, we're going to hand over to Tracy. Please do put your questions in the chat. And then after the two presentations, we will take any questions and we'll ask the two of them to answer them for you. So without further ado, I'm going to hand over to Dr. Chetty to start presenting.
Hey, Sue, am I audible?
Yes, we can hear
And
you.
my slide visible?
It is.
Okay, good evening, everyone. Thank you for that fine introduction, Sue. And at the outset, I would like to acknowledge and thank Patch and Sue, Tracy and Samantha for affording me this opportunity to present a very unique topic for a very unique and special population from my simple perspective. So let's get into it. The title of the presentation is called Falling Through the Gap: Transitioning Adolescents with HIV from Pediatric to Adult Care in Rural South Africa. And this is a palliative care perspective. Let's see. Okay, so a bit of background into where I am from. I work as a senior medical officer at General Justice Gizenga Mpanza Regional Hospital. It's a mouthful. We are a 545-bedded regional facility that services the Ilembe Health District, which is composed of 4 sub-districts. We offer healthcare services to a population of more than 600,000, and we support 3 district hospitals, 2 community health centers, and 33 primary healthcare centers. I work in the HAST unit, HAST being an acronym that stands for HIV, AIDS, STI, and TB. And this is a program that was developed to focus efforts and improve outcomes for those conditions in the state sector. And these are some of the district and regional level services that we provide. Okay. So before we get into the topic of transition, I thought it would be nice to discuss adolescence for a bit to give this presentation some foundation as to why we need to consider adolescence as a special population. So adolescence is a particularly unstable and vulnerable period in an individual's life, involving developmental changes that go beyond biological maturation and includes several other spheres depicted on the right-hand side. HIV then adds a layer of complexity that needs to be proactively managed in order to circumvent negative health outcomes. And as you can imagine, managing the adolescent thereafter requires concerted efforts from several role players, all with an aligned agenda. The biological changes that occur in adolescence are innumerable, and you can see that they affect almost every organ system. Once we throw HIV into that hat, we see that normal processes are negatively affected. And my main concern is that is on neurodevelopment. So not only does the patient end up looking different in terms of their structure and phenotype, but their physiology also changes. And in terms of neurodevelopment, we know that long-standing HIV, especially if it's inadequately controlled, leads to adverse outcomes in terms of neurocognition, development, intellect, learning, reasoning, decision-making, impulse control, and self-management, all of which are important and necessary traits to manage a chronic condition like HIV independently. In addition to destabilizing biological factors, HIV disrupts psychological and socioeconomic factors as well. And once you have this destabilized adolescent and you now expect them to transition into a complex health system, it just sets the stage for disaster if it is not appropriately managed. An important subcohort to look at is those who have acquired HIV in the perinatal period. So for those who need a refresher, the perinatal period refers to the time either at or during delivery or soon after in the early neonatal period. And the issue of acquiring HIV at such a tender age is that this person now becomes exposed to medication from a very early point, and they are at a risk for developing treatment fatigue, treatment failure, either confirmed or archived resistance, the neurodevelopmental consequences that we've just discussed. They're at risk for both communicable and non-communicable comorbidities, which can result in repeated hospitalization and complex disclosure histories with caregiver dependency. And oftentimes, especially in the rural setting, we see a lot of orphanhood and unstable caregiving, which we will discuss later. And as this child transitioned into adolescence and early adulthood, the internalized and external stigma and discrimination add another layer of complexity to this mix. So before we get into transition, I thought it would be nice to discuss the meaning of transfer. So historically, the practice has been to transfer a child who has reached the age of 12 to 13 into adult care. And this is not a hard and fast rule, but because there are other conditions that afford us flexibility as to when to transition this child. And it depends on the disease complexity and after considering whether this child is developmentally, clinically, and psychosocially ready. It's important to distinguish what it means, what transfer versus transition means. So transfer should be considered an administrative event. The child turns 12, they're issued a letter, and they're asked to go to the adult clinic, right? Transition, on the other hand, is a more holistic, developmental, clinical, and psychosocial process that endeavors to equip the child to become independent at managing their condition in a stable format and a sustainable manner into early adulthood. Transition is therefore multidimensional. We must remember that adolescents experience several layers of transition, and often simultaneously, which adds to the instability of an already vulnerable life period. And so if transition is not properly managed, this leads to an improperly prepared child who has a very poor understanding of their illness and therefore adherence. They are at risk for being lost to follow-up, developing virological failure, and the consequences of that, such as recurrent opportunistic infections, advanced HIV disease, and hospitalization, ultimately culminating in increased morbidity, premature mortality, and potentially avoidable suffering all in all. So I hope I've said enough to help you understand that transition is an important topic for today. But first, we need to look at the evidence gap for adolescent transition in SA to see where we are at as a country. So the first piece of evidence is a review article. And this study looked at I beg your pardon, this is a natural experiment and survival analysis that looked at two groups of patients after policy change. Those who turned 12 and had entered into adult care versus those who turned 12 and remained in pediatric care. And what the data showed was that those who remained in pediatric care after entering age 12 had better retention in care and virological suppression. This review article looked at 8 provincial and national South African policies to look at the degree of retention and viral suppression in adolescents. What was interesting to note is that older adolescents ended up having poor retention and viral suppression compared to their younger counterparts, and this coincided with the post-transition period. It's also important to note that most of the policies stressed clinical timing of transfer and what regimen to change the patient to, as opposed to regarding transition as a structured psychosocial and developmental process. This qualitative situational analysis, which interviewed healthcare workers across 3 different provinces, discovered that palliative care pathways were unclear, inconsistent, and poorly coordinated. And sadly, in the era of ART, HIV was not viewed as a condition requiring palliative care, even though it clearly meets criteria. Our national 2026 consolidated HIV guidelines provides a strong framework for continuity of HIV care, but a potential gap exists in terms of integrating it with core palliative care principles into this transition pathway. Similarly, our 2024 TB guideline for children and adolescents also stresses the importance of transition planning and integrating TB and HIV as a package of care. Palliative care frameworks and policies, both locally and internationally, are both aligned and stress the same point. Palliative care is an essential component of healthcare that should be applied across the disease trajectory and should begin early at the time of diagnosis. Palliative care services should be equitable in terms of access. It should be integrated into all levels of healthcare, especially at a primary level. Support for families and caregivers should be given, and this should form part of the seamless continuum of care. So the evidence presented highlights 3 important points: that structured transition matters and is clinically relevant, that a policy gap exists in South Africa as far as transitioning the HIV positive adolescent is concerned, and that the importance of palliative care integration into this transition pathway cannot be understated. If we look at the transition journey very simply, it is divided into 4 main components: childhood, when the child is completely dependent on the caregiver; early adolescence, where the child is now developing some degree of autonomy; and as we progress to older adolescence, the person develops an increasing level of independence with less dependence on the adult, with the hope that by the time they reach young adulthood, they would have developed the skills to manage their condition in a sustainable fashion. What should bring this journey together is palliative care and its principles, and that should begin and continue throughout this transition pathway. Specifically for the adolescent with HIV and TB, palliative care interventions can address physical, psychological, social, spiritual, or even familial concerns. Importantly, it should be tailored to the context within which it is being applied. For example, in the rural South African context, there are specific challenges that need to be addressed and taken into account when establishing palliative care interventions. At a patient level, apart from poverty and food insecurity and transport costs, stigma, migration, and unstable housing are becoming an increasingly common barrier to retention in care. From a family and community point of view, atypical family structures that are not led by nuclear caregivers and often have children shuffling between caregivers that may not be related to them by blood creates a whole different dynamic when it comes to managing something as sensitive as HIV. And this, as you can imagine, leads to immense difficulty when we get to the stage of disclosure. Traditional beliefs and practices are another big concern that, if not managed proactively with the relevant stakeholders, can have disastrous impacts. We work and form part of a community that is culturally diverse and have rigid beliefs in terms of traditions, cultural practices, and ancestral callings. And all of these factors need to be taken into account in order to manage the patient holistically and sustainably. The challenges with the health system go without saying, so we won't spend too much time on that. But in terms of continuity, I think it's important to mention that as a child progresses through the different levels of healthcare in South Africa, we as healthcare workers see each event as a separate event, but we must remember that the young child experiences every event as part of their one illness. So, what essentially does the adolescent with HIV need? They basically need a individualized, structured transition plan that should be designed around the person itself, him or herself rather, as opposed to designing it around the clinic that they belong to. The transition process should link pediatric and adult services, and palliative care should be integrated across the spectrum. The bottom line is that we should not be asking when should this child be transferred, but what does this young person need to safely become an adult? Whatever intervention we choose in terms of transition should be planned, gradual, adolescent-centered, multidisciplinary, geographically realistic, palliative aware, and outcome-orientated. So before we look at recommendations for South Africa, it would be important to look at what's happening across our borders. The World Health Organization and the NIH from the United States are very clear in their description of how adolescents with HIV should be transitioned, and their agendas are aligned. It is important for adolescent transition to start preparation early, using a formal individualized transition plan after establishing medical, psychosocial, cognitive, and practical readiness. It is imperative that the adolescent understands their health and well-being and goals of care very clearly. The multidisciplinary team managing this patient should have a contactable person that will form the link between pediatric and adult teams. And the handover should not just be via referral letter, but a warm discussion held over more than one time. It is important, and this is integrated with South African policies, that this transition process be integrated with mental health, sexual and reproductive health, psychosocial services, housing, support structures, employment, and community-based care. And very importantly, the strategy needs to be accessible, acceptable, appropriate, equitable, and effective, and should not require an adolescent to become geographically disconnected from care. So, putting the pieces together, this review article, as we discussed earlier, identified a policy gap. South Africa has a transfer pathway, but the international literature is calling for a transition pathway. So how can we adapt this framework to the realities of HIV and TB in the context of rural South Africa? Here are 8 recommendations that I've simplified that could potentially form the foundation for a framework. Recommendation 1 starts at the top, where a national adolescent transition framework should be developed that addresses all chronic diseases and not just HIV alone. Recommendation 2 is that palliative care integration should go without saying and should be embedded into every aspect of the transition protocol. A standardized transition readiness tool should take into account pertinent history related to the clinical, psychosocial, economical, and spiritual aspects of the child's health journey. It is important that the pathways for transition be addressed in 2 ways. Firstly, optimizing existing pathways, and then expanding pathways to exist non-traditional key role players, as I would like to call them. And these include traditional healers, alternative medicine practitioners, community leaders, religious leaders, school teachers, and taxi drivers, who are important allies to have because they often form the first point of contact for our children. Having a functional electronic referral system goes without saying, and I think that's an ongoing work in progress. It is important that training of healthcare workers at all levels be performed on a regular basis, including community leaders and traditional healers, on the basics of palliative care. And lastly, outcomes need to be measured to assess the success and failures of our intervention so that we can improve on this. The second part of the case is, the second part of this presentation is to give you a case from our clinic that serves to highlight the importance of adolescent transition in the context of HIV. It serves to identify gaps and to look at points at which transition and specifically palliative care interventions could have been offered. I hope you take some perspective from this. This is the case of a young female who was perinatally infected with HIV. She was abandoned by her alcoholic mother in early childhood and had no paternal involvement. The maternal granny became the primary caregiver, and the family of about 7 survived on 3 child support grants and 1 social support grant for many years. This child struggled with viral suppression initially, but through concerted efforts, through graded disclosure, regular and intense enhanced adherence counseling, and including this child as part of our adolescent support group initiatives, we managed to achieve viral suppression at the age of 14. But the problems didn't stop here. As she entered into her early adolescent phase and changed schools, so did her social circles. She then became addicted to alcohol and cannabis, and at the height of intoxication, and as a result of many social circumstances, adverse social circumstances rather, she jumped off of a bridge that was several meters high and sustained a T12 burst fracture with paraplegia. Following intense spinal intervention and rehabilitation, she got to a point where she was walking unaided with mild to moderate residual paraparesis. She was pain-free, she regained complete sphincter control, and was now able to perform activities of daily living independently. And she subsequently returned to school and some sense of normality. But again, this wasn't the end. Moving on to the current day, where she is in her late adolescent period, around the age of 19 going on 20. So this child was lost to follow-up, and when she was eventually traced, we discovered that she dropped out of school. She was again hooked on alcohol and cannabis. She was now engaging in unsafe and unprotected sex with multiple partners. She had fallen pregnant and is currently just past the 2nd trimester, and the father is unknown. And she now lives with a gentleman who is very much her senior, who does not know her HIV status. And on top of this, she refuses to take ART. So what's quite interesting is that this patient who demonstrated successful engagement at the age of 14 subsequently became disengaged from care as she entered into young adulthood. So this begs the question, what changed? I like to divide this analysis rather into 5 domains. So first, let's discuss the biological and clinical factors that led to her becoming vulnerable. So as we know, she had a complex clinical history that started from acquiring HIV, difficulties with viral suppression. She then sustained neurological trauma, developed complications thereof, required intense rehab, and now she's pregnant with ART interruption, which puts her at risk for opportunistic infections and acquiring other STIs. In terms of her psychosocial vulnerability, it's important to note that she has several factors, and all of these feed into each other and accumulate over time. And so if they're not proactively managed when they do present, you can imagine that the cumulative effect will have exponentially high implications. The caregiver transition is quite an interesting concept. Starting off from when she was a younger child, where she was dependent on her granny, moving on to a time when management was shared between the two, and then on to adolescent and early adulthood, where self-management became the mainstay. It forced us to question whether we intentionally and deliberately transitioned the responsibility from the grandmother to the patient. Or did we eventually reach a point where the grandmother was no longer equipped to keep her engaged, but the patient was then left to her own devices and had not yet developed the resources and capacity to manage her illness independently? Domain 4 speaks to the mental health and substance use issues in particular. And it's important to know that there are many predisposing and perpetuating factors for mental health conditions and addiction in this case, as you can imagine. Regarding her neurotrauma, although she received physical rehabilitation, we must remember that rehab of the body is not the same as rehab of the mind, identity, emotional well-being, relationships, adaptive coping mechanisms, and chronic disease self-management, which are all part and parcel of the palliative care umbrella, which was overlooked in this case. Lastly, sexual and reproductive health services. It begs the question, did this patient genuinely receive adolescent-friendly SRH services that helped her to navigate romantic relationships and disclosure of HIV therein, how to make safe sexual debut, how to negotiate for safe sex, planning pregnancies and contraceptive needs, how to navigate through gender-based violence, and how to reduce risk from STIs and cervical cancer? The palliative care perspective. So I hope from this case, you realize that this case is much more than an HIV transition case. There were several points at which palliative care needs needed to be addressed. At the time she attempted suicide and developed neurological trauma, to when she was undergoing intense rehab, to later in adolescence when she developed substance use issues and relationship difficulties, and currently when she's now she's a pregnant teenager who has disengaged from care and at high risk for psychosocial vulnerability. The take-home messages are as follows. Transfer does not equal transition. We must remember that transition is not a single static event in time, but a continuum of concerted efforts. HIV creates additional complexity to the already vulnerable adolescent. Vulnerability is unique, dynamic, and cumulative, and should therefore be managed in a similar, uniquely individualized manner. Rural, community, and culture-specific factors magnify vulnerability and should be addressed intentionally and with sensitivity. Multidisciplinary means managing together and not managing in silos with the hope of achieving an aligned outcome. And the point of the recommendation is an individualized, fluid transition framework spread across the continuum of a person's life course. Transitioning the young adolescent should be a structured and coordinated process that should be intertwined with palliative care principles. I hope this presentation has been informative and given you perspective on the importance of transitioning the young adolescent into adulthood. Thank you.
Thank you so much, Jiv. I found that so interesting. And I see we've also already got questions coming through, which is awesome. So please do put your questions for Dr. Chetty in the chat. And we will be having a Q&A session after Tracy has presented. So thank you, and we will hear from you later. And now we hand over to Tracy.
Thank you, everybody. So I was looking at that photograph, and I think it's time for an update. I didn't have one gray hair. I'm starting to feel very old. Thanks, Jeff, for that and for laying a foundation. And I want to try and look at, from my experience of working with teenagers and transitioning kiddies within a palliative care practice, how we incorporate that and how we talk to them. I'm going to ask you quickly all to open your QR codes. It's the only thing I'm going to ask you to do. They're just 3 questions that I want to explore before we continue. There we go. Sorry, it's just loading. And for anybody who was on our talk this morning, you understand how slow it is. So my first question is, do you work with adolescents by choice? Not that you just have to, but you want to. And while people are scanning and voting, just leave the app open because the next question will come up straight away on your phone. Or very interesting. I'm gathering by the votes so far that majority of people are thrown into the deep end when it comes to teenagers.
And Tracy, just to say, there's so many in the chat who are also commenting. So I'm not saying, so if you sing those, we sing them, but there are lots there as well.
Thanks, Trace. I'll have a look. Yeah. But I think the overwhelming sense is that majority of people have not chosen to work with adolescents. It's been thrust upon them. And I don't blame you because they're a scary bunch. But they're quite fun too. So while those who still have their apps open and others, please keep commenting in the group. While it loads, sorry. I love technology, but I hate it at the same time. What one word describes how you feel working with adolescents? Sorry, I'm just giggling because I can understand completely. I just want to quickly check the chat as well.
Do check the chat.
I'm having a good little chuckle here. So again, I think the overwhelming sense is that they're challenging. And if that wasn't the word, then I'm wondering if you're even working with adolescents because they're very challenging and it doesn't change. Mine are 19 and 21 and still are incredibly challenging. Thank you all for taking part. I really appreciate that. And I will have a look at the chat again later as well. There we go. So I think building on with what Jivanesh has been speaking about, I think if we look at what are the goals of adolescents, and this is a developmental stage in their life where they should be looking at a clarification of their self-image. Who am I? What makes me feel good? Who makes me feel good? It's a sense about gaining independence of that. I no longer rely on my parents for everything. Often parents become enemy number one. And of course, you know how the saying goes, hire a teenager while they still know everything. Because we as adults know absolutely nothing and they know everything. And this, of course, comes from the peer relationships that they are establishing where they find that sense of identity, that self-image. It is a stage of establishing sexual identity. And most importantly, it's about creating plans for the future. And most adolescents start thinking about what is life going to look like? Where am I going to go? What am I going to study? Who am I going to be? Where am I going to live? It's all those plans for the future. But I think when a diagnosis of a life-limiting or life-threatening illness comes, there's a massive impact on these normal age-appropriate developmental milestones. There's this loss of control. We fought so hard for this independence, which leads to the undermining of the independence. We're no longer in control of what we're doing, when we're doing it, because of appointments, clinic visits. a parent who's potentially hovering because they're so worried that something's going to go wrong. It interferes with adolescents' ability to communicate honestly and openly with peers and parents. They've already pushed themselves away from their parents. Their peers are numero uno in their lives. And now this illness is taking them away from the social life that they have become accustomed to, the chats, the whatever. And so there's this barrier now between their peers, where they get their self-image and their self-identity from, and themselves. And that leads to the sense of flawed identity in that I'm broken, I'm not normal. And it prohibits future planning. Like, why should I plan for the future if I don't necessarily have one? And it takes away all the things that the adolescent has worked so hard to achieve when those illnesses are diagnosed. So adolescence, as I said, is a time of self-esteem that's linked to peers, and their acceptance of themselves as a person is linked to the acceptance by their peers, and they're gradually separating from parents. But if we add on hospitalization, the side effects of drugs, for a child with cancer having chemotherapy, the hair loss, which all those things negatively affect self-esteem and lead in the adolescent's mind to a lack of acceptance, that they will not be accepted because they look different now, whether it's from hair loss, whether it's from weight gain through steroid usage, whatever. They feel that this identity that they created no longer exists, and they put back into a place of childhood, which is further exacerbated by their reliance on their parents, and therefore another lack of independence. So if we look at adolescents, when they perceive illness, when you ask an adolescent to tell their story, they're able to explain their illness in a sequence of events, from the time that they first got sick, to their first doctor's appointment, to the first blood test, to where they are now in whatever ward or facility they're in. They understand the nuance as their illness being a malfunction or a non-function of an organ or a bone marrow or whatever their diagnosis is. But they also realize that their psychological actions and their attitudes affect their health and illness. So a lot of us knows that adolescents are normally moody and bulgy, and especially if they're female. Sorry, I have boys. But they realize that their attitude and the way that they are dealing with their illness, if they are feeling really low, it actually impacts on their actual health and on the illness, and it almost in a way gives the illness strength. And the role that both of those have on their illness and on their health. So I think when it comes to adolescence, what is the most important thing is allowing them to be an integral part of the decision-making. As young children, if they were diagnosed early and are now transitioning into the adult practice, they have been excluded from most of the decision-making because it's been the parents and the doctors, and often within the paternalistic nature of medicine, it's been the doctors who just said, we are doing. And with this newfound independence as a teenager, not being a part of the decision-making can make them throw the decisions away. As Jivanesh was saying, Kitty's, the case study that he gave, once she was old enough, she decided to throw her treatment away. And maybe a part of that was because there wasn't enough understanding and knowledge and participation in the decision-making. We need to give information, and it needs to be a lot of information, because they are going to Google, and the best we preempt anything that they might find. But the information that we give needs to be incredibly sensitive. Teenagers, adolescents react to the content, so they react to what we're telling them, but they also react to how we're telling them. So we need to really ensure that whatever information we are giving them is done in an incredibly sensitive way to ensure that the reaction to content and delivery is not overwhelming. One of the most important things when it comes to adolescence is allowing as much choice and control as possible. And this is something that is often taken away because there's a sense of you don't know what you're doing, you're still young, you haven't lived in the world, you're making choices that aren't in your best interests. And we take away that independence, we take away that ability to think for themselves and to think about what is going to work for them. And by taking choice and control away, we also take away the possibility of them adhering to treatment. We need to be 100% honest about treatments. How often, how many, what is the next step after the treatment? All of those questions, as well as what are the side effects? And yes, we have to go to worst case scenario because we can't just give the little side effects and then they experience one of the rarest ones and then the lack of trust is lost. So it's being honest about everything that is coming from their treatment and the potential side effects. We've got to help promote independence, even though they are sick and their independence is being taken away from them because of now reliance on external factors. We have to promote it. We have to promote their cooperation and their compliance. If they buy in, our job is half done. If they feel that they have to fight us as well, then we're going to lose the battle. And where possible, we need to try and promote peer interactions. And those are sensitive conversations to have, especially if the child is no longer looking like they used to look before they got sick and treatment was started. So I just want to give some input, some examples rather of adolescent input. ZA was admitted into the healthcare system at the age of 8 with what was deemed an inactive thyroid. The thyroid was removed. Medication was given to increase thyroid function. But this went on and on and on for years. Eventually, it was discovered that it actually was a thyroid tumor, which was very rare in a young child. By the time she reached 13 or 12, going into the adult, she had been a pincushion. She had had so many side effects. She thought she was dying. The radiotherapy had caused massive burns. She had a massive scar basically from ear to ear while they were trying to get all the nodes out, as well as the thyroid that had the tumor on it. And she reached the age of 16 and they said, look, there's still tumor markers. We want to do more chemotherapy. And Zed said, not a chance. She had this long, beautiful hair, and which was helping to cover the scar. She is an incredibly beautiful young woman. And she said, I'm not doing it. One, because it's not going to work. And two, I'm going to lose my hair. And it's taken me an incredibly long time to grow it. And it's really beautiful. And it hides my scar. And that's it. So the vanity of adolescence as well. She has lived in the fear since making that decision that she is dying because she has chosen not to have any more treatment. And we eventually convinced her to come back to the hospital, which she refused to ever step foot in again. And actually her cancer markers are quite low and she's not actively dying. But before we were able to get her to do this, one of the messages that she sent to me was that I've done everything I was asked to by both doctors and my family. And this time I feel I'm going to be selfish and choose myself. I wanted a normal life. I wanted to become a doctor. I wanted a better family. I wanted a family for my children and for myself. I wanted to be loved. I wanted to get married. And now the only thing I want is to be normal like everyone else. So as much as there had been good transition because she had been in the system for so long, she felt that she was letting everybody down by making a decision that was selfish for herself. She felt that she couldn't live life because this death sentence was hanging over her head. And when we explored it, and especially after we got the blood results back, we were able to say, there's no reason you can't have a normal life. Yes, you've chosen not to have treatment. Your life may be shorter than what you are anticipating or hoping it to be, but there's no reason you can't find love and get married and maybe even become a doctor. We don't know. But what we have established is this incredibly open relationship where every fear, every frustration, her mother, she only is a single parent household, her mother babies her, which frustrates her because she feels she's a young woman. She's 17 now. Why should she be babied? She's made a decision about her healthcare. So one of the things that we've been trying to do as well is try and empower the mother to let go. Yes, their life has been terrifying for 8 years, but this is a decision that Zed has made. It's a decision she is comfortable with. It's a decision she made because her parents and her attachment to her peers was more important at that moment. And every so often she regrets it, but she knows that she's made a decision that is important to her after doing years of what everybody else wanted to do for her. And she didn't really like the adult doctors that much. She preferred the pediatric doctors. So AM is a little, sorry, my examples are far from HIV. I do a lot of work in the hematology oncology unit. AM was a little kitty with an osteosarcoma, did her initial chemotherapy, massive reduction of the mass, and refused amputation. When she was first diagnosed, she was 11, almost 12. So her induction chemotherapy was done in the peds ward. And then when she refused amputation and was then just going to be on effectively maintenance chemotherapy, she was transitioned into the adult ward. She vehemently refused this amputation. And eventually, in a discussion with her, she said, I am a Christian, but I also have traditional beliefs. And I believe that I need to go to my family home and go to the traditional healer. Chatted with her mom and said, look, I'm against it. I'm only a Christian. I don't believe in the traditional stuff. That's her dad's side of the family. But she is strong-willed and she will never accept any other decision unless she has done this. So off she went for a few months, the mass obviously growing horrendously. The mass ended up being the size of 3 of her normal legs. They had done scarification and a whole bunch of other things, but nothing changed. And she phoned me in a flat spin and said, I need to see you. So I traveled to the back end of some township. And she was angry. And her anger stemmed not from the decision she had made. Her anger stemmed from the fact that she felt that her faith and her ancestors had betrayed her. She was very happy, not happy, but she was very accepting of the fact that she was going to die and that she was given the choice and the control over her health care. But her anger and her absolute heartbreak came because she had done everything that she was asked to do by her ancestors, by her family, well, not by her family, by her faith. And they had failed her. And that took a lot of discussion and a lot of work with her. But she never gave up on the fact that her decision was right. She believed that she had done the right thing. Lastly, a little guy by the FS, leukemia. He, over the time in the ward, he was from the Eastern Cape, but he had learned to speak English and Zulu, which nobody knew. He kept it very well hidden. And during one of the ward rounds, the discussion was had that actually the treatment isn't working, we're going to stop. And he messaged his mom and said, they're giving up. And his mom messaged me and said, like, what's happening? So I said, look, I don't know. I went to him and I said, hey, dude, what's up? So he said, no, I heard you guys talking, and I know the medicine isn't working anymore, but I'm not ready to give up yet. And so I would like you to continue with your machines and with your medicine. Just a few more tries. So I spoke to the team and they said, look, okay, maybe something different will happen. And about 2 weeks after the recommencement of treatment, he called me aside and said, hey, Trace. I said, yeah. He said, it's not working. Your machines, your medicine, nah, not working. So I'm ready to go home. I said, okay. And what's going to happen when you go home? He said, I'm going to die. I said, okay. He says, but I just pray that God will grant me a few weeks at home. He had 6 months at home before he passed away. But I think what I want to illustrate with those examples is that adolescents know what is important to them. And we so often belittle thought processes because we say you're still a developing mind. You haven't lived in the real world. You haven't experienced the hardships of life. I'm sorry, being in hospital from a young age or even being diagnosed as a teenager is hardship. And we can't underestimate how that affects a child's ability to cognitively grow up very quickly. Grief and loss happens all the time around a diagnosis. And for teenagers, they have the ability now for abstract thinking. There's a lot of philosophical pondering about the meaning of life and death. And as FS said to us, he knows he's going to die and he knows he's going to go home to God, but he just hopes that he had a bit of time at home. Sometimes for teenagers, their grief appears as depressive symptoms, and often we want to just throw an antidepressant because obviously they're depressed because they're away from home and they're away from school, but sometimes that's their grief. They often think in terms of an afterlife, irrespective of religious or traditional beliefs. They have powerful emotions and they often surprise themselves by how powerful these emotions are. And the grief and the loss happens at every loss. The treatment fails. Firstly, the diagnosis, there's the grief. The inability to continue playing sport, the loss, the grief. The treatment changes my appearance, the loss, the grief. And it's important to understand as the adolescent walks through that, is that they're philosophical about this. They are wanting to change the world. They're wanting to understand each thing on a very deep and meaningful level. And we've got to try and meet them where that is at. One of the things that we experience in the setting that I work in terms of the challenges in transition is we've had kiddies who've had almost 24-hour access to their parents. The minute they enter the adult ward, the parent is not allowed to sit at the bedside the whole day, visiting hours only. Management of illness changes. The way pediatric illnesses are dealt with are sometimes very different to how adult illnesses are dealt with. And there have been several times when a 13 or 14-year-old has been diagnosed with a cancer that is uniquely pediatric, that the adult doctors have actually had to come to the pediatric hematologist oncologist and say, how do we manage this? We've never seen it before. It's not in our scope of practice. A lot of the kiddies refer to the lack of empathy or the fact that there's less empathy. Pediatric nurses and doctors and registrars, they're all more gentle. They're used to working with children. They're used to dealing with tears and with hurt and with fear, whereas a lot of adult doctors and nurses aren't. And so they're not really sure how to manage this child. And often there's a sense of that they're angry or they're frustrated with me. And that leads to the fear as well as the isolation, in that often in a ward, they are the only child. They're lying next to 40, 50-year-olds, and they have nothing in common. And these people are really sick as well. And there's nobody to care for them and hold their space. So some of the tools that I felt very helpful with the transition is the communication with the teen, the parent, and the treating team. And this, as Jivanesh said, needs to happen long before the child turns 12. But looking at where are we going, how is it going to be, what is going to be different. I try where possible to introduce them to the adult treating team, so that there's at least one face that they recognize when they go into the ward for the first time. There's a lot of emphasis about choice and control. You don't have a choice about when necessarily your drip is going to get set up, but you do have a choice about which arm, whether it's going to happen before or after your lunch. And I know that sounds really idealistic, but just that little bit of saying, can I please finish my lunch, and then I promise you I'll come and get my drip, gives that child, a teenager, just that little bit of sense of, I am independent, I have a little bit of control. Journaling, art, poetry, massive things before and after the transition. What are the fears? What are the things you're worried about? And then coming back to that journal or that art or that poetry and saying, did any of it come true? If it did, how can we help? What can we do? How do we make it different? How do we make it better? And then a tool that I use a lot is the River of Life, looking at the child's journey, the obstacles that they've overcome so far, proving that they're resilient, that they have done hard things before and they can do them again. And it's just a beautiful tool that I love utilizing with our adolescents. So lastly, I remember we need to start the process early, not when the child turns 12. And we do have some units who keep the child because they feel that they're the only ones who can really understand the condition, and that's great. But there's some units where, unfortunately, it has to happen because it has to happen. We need to include the child, the teenager, the adolescent in as many of the decisions as possible. The choices and control are paramount. And where possible, allow them, where possible, yourself be a part of their meeting with the new team. Keep communication open. Zed still messages me, screeds and screeds of messages. Luckily, I don't take too long to read. But the communication is still open, and we just keep talking, and we challenge each other, which is great. We need to learn to listen to hear, not to answer. Teenagers don't talk often, but when they do, they have formulated and thought about what they want to say. So we need to listen to hear them and not start formulating our answer before they finish talking. And we need to know that feelings are real, and we need to acknowledge them and validate them. Just because they're feeling something doesn't mean they are not capable of making a decision. We need to acknowledge them and validate them. And by doing that, we validate the teenager. Questions? Sue?
Tracy? He's still on. Thank you, Tracy. And thank you, Jivanesh, for those amazing presentations. And maybe the questions will start being thought about now, but I'm going to go back. We've had 2 in the chat, and then we'll open up the floor for anyone else who would like to put their hands up and ask questions. So the first question, I've just got to go back, was from Tracy to Jivanesh. Dr. Chetty. Thank you, Dr. Chetty. do you have a particular framework or approach to initiating gentle history taking on sexual health at the sensitive and vulnerable life stage?
Thank you, Tracy. I'm losing track of all the Tracys, but thank you. That's a great question. I'm going to post two links. One is from the CDC and one is from the South African National Integrated Sexual Reproductive Health and Rights Policy. And then we'll talk a bit on an approach. So these guidelines offer a structured approach, and they are very well-known acronyms such as HEADS, triple S, and the 5 Ps. So HEADS triple S is a framework that structures how you should take a history when it comes to an adolescent and includes the home situation, so H for home, which includes the family and caregivers, E for education and employment, E for eating, so that relates to nutrition, activities in terms of friends, social media, recreation, D for drugs, so both illicit and licit, S for sexuality, so sexual health, relationship, sexual identity. The second S is for suicide and depression, so complete mental health screening. And then S for safety in terms of violence, abuse, and exploitation. And this can be combined by the 5 Ps that the CDC advocates for. First P being partners, which should refer to old, new, if there's one or many, the genders of the partners. Second P for practices. So you have to go into the details of the nature of the practice, the sexual acts, and then risk stratify in terms of STI and pregnancy risk. The third P is for protection. So does the person use barrier contraceptive, and do they use it every time? The fourth P is for past STIs, and then the last P is for pregnancy prevention. So those are the two frameworks, right? But to answer your question is how to approach it in a sensitive manner for this very vulnerable population. And I want to answer this in 3 components, okay? 1, you need to know your patient and where they come from really well. So you need to know what language they communicate in. So this is primarily the language of communication. And you need to be versed in that language or have someone who is versed in that language to have this conversation. And secondly, sexual language. So you need to understand what the age-appropriate slang and colloquialism they use to have discussions around sex, because that will help you to identify with this person and make the conversation less uncomfortable. The second component is the environment. So these conversations need to be had in a neutral, safe, and non-judgmental space. So one needs to be quite careful about who is in the room. So unfortunately, we work in a department that's structurally very small, and we often have to share with a nurse and an intern or a student. And so it's sometimes very difficult to offer privacy and confidentiality to have these sensitive conversations. So what I do sometimes is take a walk with the patient outside or sit under a tree and just change the scenario or the context and the environment to make that person feel more comfortable. And it actually makes you feel more comfortable as the provider as well. It's also important to allow the patient to have a provider of their choice, or at least a provider that they are comfortable communicating with, and a gender that they are comfortable with. So yeah, those are the 2 environmental aspects. But I think the third and most important aspect that needs to be addressed when it comes to appropriately taking a sexual health history is assessing you and being in control of you as the provider. So you have to be very aware of yourself, and you yourself has to become comfortable in taking a sexual health history and talking about sex and all the complexities and difficult concepts that it entails. Because if you yourself are going to be hesitant or show a discomfort, that's going to come across to the patient as something that this is wrong to speak about, or it's uncomfortable, or it shouldn't be happening at my age. And that just sends the wrong message, and you're not going to get very much information from it. So the aim is to be confident and comfortable in speaking about everything sex-related. The second thing is, if you know your patient well enough and you've established good rapport with them, then don't pussyfoot around things. I don't think it's helpful or beneficial to the consultation to on the side of caution. I think if you want to know information, you should go out there and ask it. And that brings me to the third point, which is your patient needs to know why you're asking this information. If they understand why, they would be more willing to volunteer the information, or at least answer your questions honestly. And the last thing to be aware about, and often with colleagues, we in my department at least, we give each other feedback from consultations, and it speaks to being aware about your body language in a consultation. So, as Tracy alluded to, when it comes to personal beliefs and judgment and religious beliefs, it's so important not to make that scene or portray that in the consultation, because that you're going to lose rapport with your patient. So be mindful of your tone of voice, your negative body language, facial expressions, eye movements and expressions, because these are little nuances that can negatively impact the success of taking a good sexual health history. So yeah, I think those are the three main important points, that knowing your patient, knowing yourself, and then the environment within which this conversation is had. But out of interest, the two personal sort of situations that has allowed me to become more comfortable in taking a sexual health history is one, having colleagues come to me for issues related to sexual health, or acquiring an STD, for example, and having to take a history. You have to show up and be completely present and confident in that setting. And the second, which is a little bit more uncomfortable for a lot of people, and I just happen to sort of derive some confidence from it, is seeing sexual assault survivors. So one of the doing the forensic analysis and assessment and kit for sexual assault survivors is something that I've become a bit more proficient in. And in that context, you have no choice. It's not about how you feel or how the patient feels. You have to get to the bottom of the history taking. And so you have to be quite direct. So yeah, to cut a long story short, yeah, I hope I've answered your question. Thanks, Tracy.
And Tracy did put in the comment you had answered a question, and thank you for going into that explanation. I think it's a topic we often avoid, or we don't want to go there. It's a space that is not for discussion, and I think it's so important. So thank you for opening the floor and opening the discussion on that, Jiv. We appreciate that. Thank you. I do have
We've lost you, Tracy. Please do raise your hand or put a question in the comments if anybody else has a question. Jane, put your camera on and see that.
Hi, thanks for that. Tracy, just wanted to mention and ask you, coming mainly from an adult perspective, but recently seeing a 15-year-old teenager, I found the biggest problem was his design, knowing that his back was against the wall, nothing else was going to work for his leukemia, and wanting to come home. And yet that going against what his parents wanted. and very difficult, because normally dealing with adults, you're dealing just with the adults. And here it was a case of balancing what the teenager wanted and what the parents wanted. So I don't know if there's a solution to that, but I just found that particularly challenging, as opposed to just dealing with an adult.
Yeah, thanks, Jane. I think that is always a difficult scenario, because we have to respect the child. And I think for me, what we have done in the past is try and understand the parents' fears for why they don't want the child at home, but also to try and create a family meeting where everybody can express why they want what they want. And in the end of the day, for us, working with parents, irrespective of the child's age, I mean, I've had a 6-year-old say that's that I'm going home, is really trying to promote the best interests, in that this child, this teenager, this adolescent, whoever doesn't want to continue with treatment, doesn't want to die in hospital, wants to be surrounded by their friends and family, and really encouraging the parents to understand that that is important to them. And if the fear is, I don't know what I'm going to do if they die at home, then we make a plan. We talk about what we can do. How can we help? If there's the fear of a massive bleed, especially with a kid with leukemia, one of the things you can do is make sure that his bedding is dark, so that it's not frightening for you, for him, for the other children at home. But I think for me, what is paramount is trying to get everybody to understand each other's point of view and desires, and to really promote that at 15, he is independent enough to make that decision to stop treatment, or to know that the treatment has failed and there are no other options, and to be at home. But it's a continual conversation. It's a continual trying to address the fears, try and give each fear a solution, for want of a better word. But really, it's about that family meeting, and about really trying to promote the patient's needs over the parents. I'm not sure if that gives you enough insight, and I'm happy to chat more about it if needs be.
Thanks, Tracy. Sorry, I lost connection for a little while there. Tracy, there's another quick comment and question from Tamara. She says, in terms of transition from peds to adults, we often want to keep our 12, 13-year-olds a bit longer, but are pressurized by the system to transfer. Is there any DOH policy that allows us to delay transfer if it will adversely affect the patient?
Yeah. Hey, Tamara, thank you for the question. Unfortunately, the DOH policy is at 12. And Jivanesh, I'm sure you can add to this. I think one of the issues sometimes is around nurses who don't want that older child in the ward. But I know colleagues who have, especially if the child is small and stunted because of their condition, have not reached their milestones in terms of puberty, and hence the potential of sexual awareness, that they have kept them in the ward. But it's about getting buy-in from everybody in the ward, especially your nurses. But there isn't a DOH policy, as far as I'm aware, Jivanesh, you can correct me, that can allow you to keep the child in the ward.
Yeah, I agree with you, Tracy. The guideline that comes to mind is the National Adolescent and Youth Health Policy. It doesn't explicitly say that it disallows you, but it always puts the care and well-being of the child and their progress in terms of their health journey at the forefront. As it stands, I think it does vary between institutions, and it really is dependent on human resource allocation and capacity to keep the child. But it usually is a multifactorial situation. So I don't think there is a clear-cut answer, but I think Sam might have more to add.
Yes, thank you, Sam. I see your hand is up.
I just want to say it brings us to a very important question, and going forth in all our careers and in our hospitals is to start talking about adolescent care. And we need to have like-minded people and champions to start creating adolescent care within our institutions, because many of you have voiced concerns that, they are a forgotten group of people with explicit needs and that needs to be taken care of. So you need to make a team of people, and you need to have champions to start that process. And I've just done the adolescent course with UCT, and it was mind-blowing. And to see how one person just made small changes, and how it takes you to just get to be that person to start this process. So, Tamara, you are so right. People want to keep their patients. They are small, they're tiny, they don't have any Tanner staging. But like Jivanesh and Tracy said, there's so many factors involved. But I do feel we need to start talking about adolescent care because that transition needs to happen. We need to start thinking about them.
Thank you, Sam. Are there any other questions or comments anyone would like to put to the presenters? Okay, well, thank you, everybody. If we have no more questions, I'm just going to share my screen. And I would appreciate if all of you would complete the survey. And just before I do that, I will put the code up. If we could just hand over to Sam, and if she would just say a word of thanks to our presenters. An amazing evening, and I think so much to walk away from this evening. Thank you.
Thank you, Trace. I just want to say a heartfelt thank you to Jivanesh and Tracy. You guys have put in a lot into the presentations, and it was a lot of knowledge. I've learned a lot of things from both of you to take forth into the teams, and I hope the audience has as well. So thank you so much. There have been so many important points that you have showcased to us, and I like the way you have approached the topic and embraced it and brought the palliative care concept within the talks as well. And as you can see from the audience and our people who have joined us, they actually really appreciated you sharing that information with them. So thank you so very much. I truly appreciate you both. Tracy, I will hand over to you. And yeah, many of us are even saying, please do stay and join to complete our survey, because we do need that information from you guys to make our webinars in the future be worthwhile to you, and your feedback is very much appreciated.
Thank you, Sam. And yes, thank you everybody who took the time out this evening to participate. We really, really do appreciate it. And we, just to let you know, to look out, we will be hosting another Patch essay webinar series in November. So do look out for any flyers, or look on social media, and we will be putting that together. So thank you everybody for attending. Thank you, Sue. Thank you, Tracy. Thank you, Jivanesh. We really appreciate your evening with us.
And my thanks to everyone. I see there's a question about sharing the PowerPoint. Tracy and Joe, would you be willing to, if I turn them into a PDF, would you be willing to share your PowerPoint?
Yeah, absolutely, no problem.
Right.
I think they also wanted the articles on the resources that Jivanesh used in his presentation as well on the
Yeah.
transition?
It will be in the video. So our videos within a day or two, I'd upload to YouTube and you can access them. I did put it in the chat. We have a page on our website where you can access all our webinars. So please do go and look there, and I will also put the PDFs of the presentation if you're happy to share.
Yes, of course.
Ah, awesome. Wonderful. Thanks, everybody. Thanks for your time. And do complete our survey, please.
Thank you, everybody. Have a good evening.
Just giving people time to complete the survey.
Yeah.